Welcome to Speech Scope, a MedBridge podcast where we conquer challenging topics for the medical SLP. Our aim is to deliver actionable takeaways for clinicians like you through captivating discussions with experts in our field. To receive continuing education credit for this episode and access bonus resources, make sure to check out medbridge.com. Hello, I'm your host, Sarah Baar, a clinical SLP in Michigan with over 15 years of experience. I specialize in adult neurogenic disorders and the life participation approach. Today, I'm excited to be joined by Dr. Adam Lloyd, clinical assistant professor in Otolaryngology and Vocal Performance at the University of Miami Health System, and an expert in the area of voice disorders and vocal pedagogy. We'll be diving deeper into this topic, including recent research and actionable takeaways you can implement right away. Welcome, Adam. I'm so glad you're here. Can you get us started by telling us a little about yourself?
Yes, thank you so much, Sarah. And it's just such a pleasure to be with MedBridge again. You guys are such a great company. Thank you so much for the opportunity. So a little bit about myself. I grew up in Tennessee. I grew up singing. So from, I think, the fourth grade on through high school, I was in the choir and in musicals and always enjoyed being a part of a group. Did a lot of opera as well when I was coming up into my undergraduate degree. So I majored in vocal performance and in my undergraduate experience, as well as did a master's degree in vocal performance. And then I had a problem with my voice, which I'll talk to you about in a little bit because it's a little bit about my journey into speech pathology. But outside of that, I enjoy cooking and being outside. I live in South Florida now and hanging out with my family and friends and my fur baby, Milo.
Oh, awesome. Well, that sounds like a great start and kind of you have an interesting story into how you got interested in speech pathology. So share a little bit more with us about what attracted you to voice disorders and what led you down the road to speech pathology.
Yeah, so it was through fear, actually, that led me to speech pathology a little bit. So as a singer, I started having problems with my voice, and this was right after I was finishing my graduate work in vocal performance. And actually that summer I was scheduled to do 7 performances.
Oh, man.
And it was a really scary time for me. So actually I went to a voice specialized clinic in Tennessee and ended up, having some rehabilitation for my own voice and met with speech pathologists and laryngologists there. And had such an eye-opening experience because I was already involved in the pedagogy side of voice from my music training, as well as my own teaching. I was teaching at a community college then, voice lessons.
Oh, wow.
And so when I found out that you can sort of bring together the medical aspects of things and the voice exercises and pedagogical aspect of things, I was like, wow, this is an amazing career. I want to learn more about this. So I went back to school for speech pathology and never looked back after
wonderful.
that. Yeah.
Sounds like a great fit. And have you been teaching, practicing? How do you usually spend your day-to-day right now?
Sure. So when I first finished graduate school for speech pathology, I had some research experience in graduate school, which just really lit a fire underneath me. So I worked and did my clinical fellowship at a private practice voice care center and then worked there for 3 years after that. And then started to just feel like I wanted to contribute to the field in a different way. And so I took a position at the University of Miami where I am currently, where I was able to engage more in the research process. And, that's kind of my day-to-day is I am in the clinic, I do research, and I also do some teaching with the School of Music and our residents and fellows and things like that.
Oh, sounds like an awesome fit. And you've had so many cool experiences to lead you to this place. So, well, thanks for being here. Today, we decided to focus our discussion on functional voice disorders. So I am so excited to learn from you. Probably everybody listening knows I'm not a voice expert, but I love to know what is going on with the latest research. So let's start our discussion today, just like getting everybody on the same page about this topic, functional voice disorders. Can you review, like, what are we talking about when we say that, and why is this a clinical challenge for SLPs?
Sure. So functional voice disorders, it makes me think of, and what we read about in our textbooks, is usually a voice problem that occurs despite having normal anatomy. So when you look inside someone's throat and you don't see a lump or a bump or something like that on their vocal folds that would be causing the voice problem, the dysphonia, it's the function of the mechanism, the function of the muscles that contribute to, let's say, strained vocal quality, which is a typical vocal quality that someone with a functional voice disorder might have. And so, this might include a host of different types of pathologies. Some of the ones that we may be the most familiar with, one is called muscle tension dysphonia, where the muscles in the neck or inside the throat will be tense and cause symptoms like vocal strain or hoarseness or complete voice loss. Other things that, someone could have complete voice loss where they can't make any sound at all, related to functional reasons of their voice. They can also have problems by losing their voice because of an emotional distress. We call that like a conversion dysphonia or aphonia. And they can also have a dysphonia as they develop over time, usually happens to teenage boys, where their bodies will change, but their voice remains high. And so we call that puberphonia. Those are just some examples. There are other things that might fit underneath the functional voice disorders category, but those are some of the main ones.
Great. Thank you. Why is this kind of challenging? I mean, I think I already know why this is challenging if nothing shows up when you look inside, but why don't you talk a little bit more about why this is a clinical challenge?
Yeah, I think it's a clinical challenge because there's nothing physical that you might see anatomical wise. Now you can see some representations of muscle tension, but even that during an endoscopic evaluation is not a good indication of a voice disorder. You stick a scope in someone's nose, they're not going to be perfectly relaxed. Right. So because of the lack of physical findings, and also this population will sometimes present with intermittent symptoms. So they may come into the clinic for an evaluation and they may be telling you about their voice problem, but then they don't actually have the voice problem at that moment in time. So it can be challenging to really know kind of what's going on, and you have to really rely on their case history in that example, and the situations surrounding when they do have the problem.
Yeah, and I can imagine with like intermittent problems, or you're not seeing something when you're scoping them. Just the patient might be like, "Do you think I'm making this up?" Or kind of have that attitude. And that's probably the last thing you want them to feel like also.
Right. And it's also a challenge because when people come to, like, I work in conjunction with my laryngology colleagues. And so we see patients at the same time. And when they come to the voice evaluation, they almost want to find something physical so that it can be taken care of.
A little more straightforward.
Yeah, straightforward. Yeah, exactly.
Okay, well, thank you for the background there. So let's just talk about the recent research then of this kind of messier subject. So when we're thinking about functional voice disorders, can you give us just some high-level takeaways of what the most recent research is looking at or sharing?
Sure. So we have some pretty good research on hyperfunctional voices. Some of the therapy protocols that have been investigated would be like laryngeal manual therapy. We've had some research on flow phonation and resonant voice. There's quite a bit of research on vocal function exercises for hyperfunctional voices. And then we have some less research, but a lot of writing and textbook chapters and things like that on like facilitating techniques and symptomatic therapy techniques like yawn sigh and reflexive voicing tasks, which is a big thing with this population. Like an example of reflexive voicing tasks would be like, if you can't make a phonated sound when you go, "Hi, how are you today?" Can you cough? Because if you can cough and make sound, then maybe we can turn your cough into a voice.
Yep. Okay.
So, but in terms of research that's out there, I really enjoy reading the research on manual therapy techniques. It started with Aronson in like the 1980s and 90s. Roy and Matheson has done some really great work on that. There's been a recent systematic review this year, actually, that looked at the effects of circumlaryngeal massage, and they've shown improvements in like acoustic measures of the voice. When you think about like, voice, you want to include voice in your voice therapy, not just rubbing someone's neck,
Sure.
although that is a great therapy technique to reduce tension. So, some of the elements that we need to include in therapy techniques are actual phonation, thinking about how we pair that with the respiratory function, as well as making sure that someone can describe and understand the sensations that they're experiencing during voice production. So some of the therapy techniques involved in that would be like flow phonation, which has to do with feeling a sensation of airflow. Ragnaratham and colleagues in 2023 last year did a nice study on flow phonation, and they looked at that plus vocal hygiene, and they found that there were improvements in vocal quality with that technique. Another technique, resonant voice therapy, is kind of a hallmark for voice therapy in general. It focuses on feeling sensations of vibration and feeling ease of phonation. That actually comes from theater training, and that has been looked at by Boone and McFarlane, written about that, and most recently by Verdellini. Lastly, in terms of the voice, we have a lot of research out there that's on semi-occluded vocal tract exercises, including Stempel's vocal function exercises. And they have been found to have positive effects on quality of life and perception of voice.
Awesome.
So there's a lot that's out there.
Yeah. I hope like maybe on the handout, we can include some of the links and references. It sounds like there are a ton of recent articles, which is awesome. And it's always nice when there is something to do, right?
Yeah.
So overwhelmingly, I'm hearing, there's like several different evidence-based options to support functional voice disorders and restoring phonation. So let's spend some time talking about the clinical flow and how SLPs can use that research and translate it into their clinical practice and just the actions and decisions that they make. So let's start with the assessment, if you are good with that.
Sure.
What are some of the distinguishing assessment tasks or results that we might see to lead us to think, okay, this probably is a functional voice disorder?
Yeah. So first of all, we need to get a really good case history and understand the timing of when it happens and when it's exacerbated. We also need to understand the course of their voice problem. Like, does it get worse when they're at work? Does it get worse when they're dealing with a stressful situation? So the case history is very important to really understanding what are the contributing factors. Does it get better? And if it does get better, what helps it to get better? In our evaluation, we standardly will do acoustic and aerodynamic measures of the voice. This may not necessarily differentiate between other types of pathologies, but it's good objective information to get.
Yep.
The laryngeal exam is going to be key because anybody can come into the clinic and say, I'm hoarse. What's going on with me? But, we can't really determine what's going on unless we have a really good laryngeal exam. And that laryngeal exam needs to include video stroboscopy so we can see the actual vibration of the vocal folds. So once we rule out that there's no anatomical reason for their pathology, we can start to look at, other markers. Do they have supraglottic compression, like the muscles above the vocal folds? Are they squeezing on in and around the vocal folds? And that could be a marker of hyperfunction. But really, I think the number one thing that helps us to distinguish and really be able to diagnose this functional voice disorder is our ears, is hearing the voice and hearing that person describe, their voice. So, that is something that a good clinical ear is going to be able to distinguish between. Once we rule out anything anatomic, a good clinical ear is going to be able to distinguish between different types of functional voice disorders, even distinguish between some types of neurological voice disorders that can sometimes masquerade as a functional voice disorder.
All right. Can you give us some ideas about the types of goals that would be appropriate to address when you're treating someone with a functional voice disorder?
Sure. So I think the first thing, and sometimes the most challenging thing, is to explain the problem to the patient. Like I said earlier, when someone comes in, they want to have a concrete understanding of why they're experiencing the problem they're experiencing. And if they have an anatomical change in their vocal folds, then that's a clear reason as to why they're experiencing their problem. So if we explain to them that this is a muscular problem, a functional problem, we need to do a good job of explaining, why that, what that means and how that's happening. Sure. Another thing is to understand how to help them understand how they practice the techniques that we're teaching them in therapy effectively, independently. So often patients will come to therapy and they'll do a good job when we're sitting there with them, guiding them through, but they have to be their own therapist when they're not with us. So being able to continue along with that stimulable voice on their own is very important. Typical goals for any type of voice disorder, speech or language problem would probably be being able to do a hierarchical approach of a therapy. So starting with a basic sound, working into words and phrases and into conversational speech eventually. And the ability to recognize what is causing their voice problem to get worse and being able to intervene before it causes their voice to regress.
Mm. I'm curious if you have any analogies that are your go-to analogy for explaining, when it's well, it's not like a broken bone. It's not like there's a cyst on your vocal fold. I don't know. Do you have any in the voice world that you tend to go to help explain the concept of a functional voice disorder?
Yep. I sometimes use the analogy of let's say that you're sitting at your computer and you're raising your shoulders up like this and typing, you don't even realize it. And then later you think, why are my shoulders so sore? Why is my back sore? Why does my neck hurt? Well, it's because your muscles were being held in a way that's causing the symptoms that you're experiencing. So
that's great.
People often relate to that.
Yeah. Now I think you helped us relax for the
rest of the Let's shake it out.
That's great. Okay, let's move to treatment approaches.
Yeah.
Let's talk about then some of those treatment approaches, and you kind of gave us the high-level view of some of those. What would make you choose a certain approach, and how might that play out into therapy?
Sure. So I think most clinicians are going to start with what they think is going to be the most successful for that particular patient, given what they know about the voice problem. I tend to be a little more hands-on than some other clinicians, so I really like the laryngeal manual therapy approach. Some patients don't like to have their neck touched, so of course we were going to respect that and pivot if we need to. But I think oftentimes people don't realize how much tension they can carry in the extrinsic or intrinsic laryngeal muscles. And so I often will start with a manual therapy, like a reposturing exercise, where you're pulling down on the sides of the voice box, trying to relax the voice box down a little bit. There's other circumlaryngeal therapy that goes along with laryngeal manual therapy and things like that. And I think that that can be very effective for a lot of patients with functional voice disorders. I will often use mindfulness techniques as well. Mindfulness is not just in speech pathology, it's in a lot of different fields and, of course, in mental health fields. And so mindfulness, not that we are, certified mental health anything, but we can recognize that stress and anxiety and depression and all those things can contribute to someone's voice problem. And there is plenty of literature out there to support that. So doing something just to help relax the mind and the body, I think is very effective in being able to manage functional voice disorder. And then I will get into various physiological voice therapy techniques, like I mentioned earlier. I love flow phonation because of the sensations that someone can feel with airflow. So for example, having someone put their fingers in front of their lips and blowing into their fingers to start, and then adding air, ooh, and then adding a word, feel, flow, or a sentence, feel the flow of air. It gives them something that they can, like a biofeedback sensation that they can feel and relate to their voice and try to stay relaxed at the same time.
Great.
Yeah.
And then with each of those, so you'll kind of pick your techniques, go through it in therapy, and then are you starting really right away with the client of just trying to get them pretty independent with doing it also, so that when they go home, they can, correctly continue what you've started? And do you do that for the manual techniques also?
Yeah, there are certain manual techniques that are a little bit complicated. So we do them in the clinic and then teach patients certain ones to do on their own. But I would say, answer your question, I would say, yes, we want them to be independent as quickly as possible. And, one of the newer therapy techniques that we have, or newer concepts that we talk about now in voice therapy, is this concept of conversation training. So we take the patient right away into using their voice in a therapeutic manner in conversation. Because one of the hardest things to do is to transfer a sound into a conversation with someone. So if you get them working on conversation right away, then it's a really nice way for them to be able to be independent.
Yeah. I like that. That reminds me, in the adult neural world with language, there's this, it's called the complexity theory. And they've just found if we, instead of starting at the littlest building block, but just kind of go to the end goal, that's kind of what it sounds like. And then those other little pieces tend to fill in. So that
you can always go back to the little pieces if you need to, it's called a basic training gesture, like doing a flow phonation or a resonant hum or something like that to bring them back to that if needed.
Yeah. Cool.
Yeah.
Was curious about, with this population of functional voice disorder, how often are clients with this diagnosis also working with psychology or mental health professionals? And I wondered if you had any wisdom to impart for collaborating with that part of the team.
Yeah. So I don't have exact data on that, but just anecdotally, I would say probably 25% of our patients have emotional complaints or emotional distress, like that they report stress, anxiety, depression. And I think that bringing it up is touchy sometimes because that is not really our scope of practice. But the way I look at it is looking at the whole person and not just their physical body. And I bring it up right away, usually in the evaluation, ask him how are you doing? How's your stress levels in your life? Do you feel like stress makes your body feel tired or tense? And I think that's a pretty easy way to then, bring that up. Because if they answer in the affirmative, then that's a great segue into saying, like, do you have someone who helps you manage this, or how do you manage your stress and anxiety? And, we can make some referrals if you need, a list of people that you can, talk to that are specialized in working with people who have voice problems. But I think it's very effective. Both myself and several of my colleagues that I work with are very invested in making sure that we have those connections with our mental health colleagues, so that we can easily make those referrals.
Yep. Awesome. Okay, so I'm hoping this next question can be a safe conversation here. We're not really trying to throw anyone under the bus, but you are a voice specialist, and some SLPs who are listening are more in the position to be a jack of all trades, and that is how a lot of jobs are. So as someone who's a specialist, do you see common mistakes or actions that you wish would be done differently by SLPs who are in more of that generalist position? And I was thinking about this specifically for the functional voice disorder population.
Yeah, that's a great question. I think that we do what we know, right? Obviously.
Yeah.
I mean, for everything in life. And I think that a lot of people, including myself, have a long history of hearing about like abdominal breathing for voice, right? And it's not that that's a bad thing. That could be very effective in establishing a good breath coordination and maybe relaxing. But one size does not fit all. So like this podcast, or like various other review articles or webinars series on MedBridge or other courses, there are techniques that you can learn about or review that are not just like the basic abdominal breathing, right? So we have to kind of familiarize ourselves with what other treatment approaches are out there, so that we can make the best educated decision on what's going to be best for that patient.
Okay. I'm going to have a question.
Yeah.
When you say abdominal breathing, is that diaphragmatic breathing?
Yes. Yeah.
Okay. Here in Michigan, we just call it. So I'm going to say it because you're saying it so nice, but not everybody needs to work on diaphragmatic breathing. Is that what we're saying?
Well, here's the thing. Like, we breathe from our diaphragm no matter what, right? It's just a matter of like, are we being tense about it? Do we breathe in a hyperfunctional way? Or maybe we don't breathe enough. Maybe we're not taking enough breath. But I think the biggest mistake that people make is relying too much on an isolated, unvoiced exercise. Yeah. And so we need to get to voicing, right?
And the whole picture.
Yeah. And to make the point that we were talking about earlier, we need to get to voicing in the context of conversation.
Yeah.
Right? And make some carryover there as quickly as possible.
Wonderful. Thank you. Any advice, Len? I mean, we are like talking about this with sympathy of like, not everyone can be a voice specialist. And so do you have any like tips for those?
Yeah.
Individuals?
Yeah. So if you're working on certain goals and you feel like they're just not getting the patient to where they need to be, then switch, do something else. It's been surprising to me sometimes where I'm working on with a therapy technique that I'm like, this is a good therapy technique. Like, you should be making progress with this therapy technique. I'm not quite sure why you're not, but you should be. This is what you need. And then I pivot to something else, and then they make progress. So it's not necessarily about the therapy technique. It's knowing that there are options out there, and stimulability is something really important. So if like a resonant hum, like focusing on resonance is not helping, focus on airflow or focus on relaxation, focus on mindfulness, do something different, focus on a vegetative task that can spark a voice. And if all else fails, phone a friend. Yeah. That's why we have the SIG3 communities at ASHA. That's why we have the ability to, contact each other and to, support each other.
Awesome. Great advice and great permission that it's like part of our job to experiment and not everything is like rigid. So
Yeah. Yeah.
talking maximum impact, what would be your top 3 actionable takeaways for clinicians to put into practice for the functional voice disorder population?
Yeah. I think we need to listen to our patients. We need to get a really good case history. We need to let them talk. So often we will hear a lot of key information when we let them talk. And I say this with a caveat that obviously sometimes we do have to redirect them if they get off topic. But, listening to their story is very important. Also, training our ears and listening to their voice is also very important. I think that we need to be able to relate to them, and that is part of, I think, how we can build their trust is listening to them and explaining like, oh, I understand that must be difficult for you. Tell me a little bit about, what exacerbates your voice problem, getting to know your patient in that way. And, like I was saying before, I think one of the most important things that we can do is experiment within the context of evidence-based therapy and what we have available to us. Is, if something's not working, then experiment with something else. See what they are stimulable for.
Awesome. Just a little thought that popped in my head. How long do you think these type of disorders, like how long is the duration of therapy typically, or just does it totally vary?
Yeah, it totally varies.
Okay.
Because I have seen a patient one therapy session and they were totally cured. And then I've seen patients for more than 10 therapy sessions.
Okay.
Usually not, but occasionally, they may need a longer course.
The one session clients must just make you feel like you are doing the best work ever.
I'm the king of the world when that happens.
Like, all you needed was Adam's touch and you're healed.
Yeah, no, it's funny. One of my laryngologists, when he first came on staff, we had a patient who was totally aphonic and like wasn't even moving airflow when she was talking. And he was like, I don't know what to do with this patient. I was like, let me try some voice therapy. And then the next time she was in the clinic and he was in the clinic, I said, come on in here. I want you to see your patient. And she started talking to him and he was like, oh my gosh. Yeah, that was pretty cool.
You're like case made for speech therapy.
Yeah.
We are super important here. So
that's right. That's right.
Awesome. Okay. Well, I thought what we could do next is just help our listeners apply some of these ideas we've been talking about through a couple of hypothetical but still applicable examples or case scenarios.
Yeah, sure. So I have a couple cases that in my career that have been kind of sticking out to me. And I had a patient one time that came in who was severely strained. This was kind of like this. And, getting to know her, she had a job that required a lot of voice usage. She was an administrative assistant. And she would say that, after a couple of hours at work, she would come in first with a normal voice. And then after a couple of hours of work, she would be like that, like I demonstrated. And so this was actually the patient that I did one therapy session with. And we focused on relaxation techniques. And a big part of what we did was circumlaryngeal massage. And her voice went from being like that to back to completely normal.
Wow.
Yeah. So that was pretty cool. A couple other examples is I had a patient who was 17-year-old young man who, normal birth, normal development, otherwise normal anatomy, but had just maintained a very high-pitched kind of voice, and his voice would break like this very frequently. And so actually, he was a very challenging case because I threw the book at him in terms of therapy techniques. And eventually he was diagnosed with puberphonia, meaning that he maintained a high-pitched voice despite having normal developed male anatomy. Finally, I was doing some reflexive voicing tasks with him, and doing like a cough into voicing, like huh, huh, and then we heard his voice come out, like a lower pitched, comfortable voice for him, and we both kind of went like, "Whoa, what was that?" And interestingly, he wasn't able to maintain it like that, but what helped him was actually doing a vocal fry sound, like into that, to be able to maintain a comfortable lower pitch voice. And then he was able to build on that, which was pretty cool.
That's a cool example because like both of those, right, are kind of behaviors that you typically want to like limit. Like you don't want to do too much coughing, or you don't want to do, but that for you, those were like the facilitators, and just a good example of what you mean when you say like experiment and try different things.
Yeah. Because we don't actively think about a cough as being voiced. It just sort of, our bodies just sort of go on autopilot to do that. Mm-hmm. Sometimes that can elicit normal voicing.
Cool.
Yeah. And then another case that I was thinking of is, this is a patient I saw several years ago who came in, and she had kind of a whispered, strained voice. It was kind of like this. And when you look inside of her pharynx into her larynx, her vocal folds were completely covered over by her false vocal folds. So there was a lot of strain and tension in her intrinsic and her extrinsic laryngeal muscles. So, I did quite a few different types of therapy techniques with her. I did resonant voice therapy. I did manual therapy on her neck. I did relaxation. We did flow phonation. And after about 8 sessions, her tension subsided, and she didn't have a normal voice though, because underneath that muscle tension dysphonia was a secondary, was really more of a primary voice disorder, which was spasmodic dysphonia, also known as laryngeal dystonia. So she had sort of superimposed a lot of tension, like a secondary muscle tension problem, functional voice disorder, over a neurological voice disorder, which was underneath all of that. Wow. So it was pretty cool to uncover that. And then she was able to get Botox treatments for her spasmodic dysphonia, which made her voice more or less normal for a period of time until she had to get re-injected.
Yeah. Wow.
Yeah.
Just a side note to say, your voice like replications are very impressive. In my head, I'm trying to see if I could do it, and I couldn't do it. So.
Oh, I have lots of examples like that.
Yes. Do you make your class do those also as they learn things, or no, not really?
Actually I do. It's funny because I'm teaching voice disorders this semester, and because I think it's important to be able to understand, how to make that sound so you can understand what the patient is going through in order for them to make that sound too.
Oh, that's great.
So, yeah.
I had a question when you were talking about your case studies, and I would imagine that some of these clients possibly have had a functional voice disorder for like a very long time, maybe even like years.
Oh, yeah.
And so they've kind of been functioning in that not correct way for quite a long time. But do you feel like there always could be progress? Like people can relearn, and even if it's been like, they've been like this for 5 years, or I don't know. Do you get what I'm saying? Do you have any thoughts on that?
Yeah, 100%. I think our bodies are always ready for change. They talk about like, that in the, I think it's in the 40s or 50s that we start to lose muscle tone, but we can actually gain that muscle tone back to a certain extent by doing exercise. So yeah, we can certainly change the way our muscles are reacting over time, especially if it's more of a functional voice problem.
Awesome. That's, really encouraging to hear, and hopefully for our clients as well. Okay. So, as we wrap things up today, Adam, can you wrap us up with some final words of wisdom or inspiration that you just want to share with the audience?
Sure. Like we mentioned earlier, I think working with functional voice disorders is one of the areas of speech pathology where the speech pathology can be the real hero for that patient. And so, we owe it to that population to really be good at treating them. So get to know some of the therapy techniques and to be able to, pivot if you need to. We can go from having someone have no voice to having a completely normal voice in a very short period of time when we are, able to implement those therapy techniques appropriately. I think we really need to listen to our patients, listen to their stories, learn from their unique experience. And, if something's not working, then change it up. If all else fails, the cool thing about medical-based speech pathology is that, we don't work alone. We work with our medical colleagues. And so, if you feel like you've maximized everything that you can do in therapy, and you've phoned a friend and you tried everything, talk with your medical colleagues to see what other options do we have for this patient. Maybe we're missing something here. And that's what I really, truly love about voice disorders in general, is that it is a sincere collaborative effort with our medical colleagues.
That's wonderful. I love that. I'm going to take with me like SLP hero too. Like, this is pretty great. And thanks for being our hero today. That's all the time we have for today. Thank you so much to Adam Lloyd for his insight and clinical takeaways related to functional voice disorders.
Thanks so much.
Thank you for tuning in to this episode of Speech Scope by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or on your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and search for this episode to find the accreditation details. Speech Scope also listens to you. If there's a particular clinician that you'd like to hear from, or if you have a clinical question or challenge that you'd like to see addressed on this podcast, please let us know by leaving a comment on our Instagram posts or by emailing podcasts@medbridge.com.